Okay, we're going to finish up chapter 75, starting with the prostate cancer. And I'm not going to read these slides to y'all. I will add any additional information that you need. There are some slides that you can simply look at, and I'll just click right through those and just give you the extra information that you need, so you don't have to listen to my voice any longer. All right, so we're going to start with prostate cancer, second most common invasive cancer, but it follows lung cancer. Usually it's found in the posterior lobe or the outer portion, and 95% of these cancers are adenocarcinomas. Metastasis is usually to nearby areas such as lymph nodes and bone marrow. The later disease spreads to visceral organs. Bone pain, considered a late sign because prostate is such a slow-growing cancer. These patients generally will present with difficulty urinating, retention, or frequent urinary tract infections. All right, the best way to find it is doing digital rectal exams and PSAs, beginning at age 50. There's guidelines in your book on page 1719. The CPSA is a little more specific, for prostate cancer, and as I said, over 50. Risk factors for prostate cancer include diet high in animal fat, family history, African Americans, vasectomies, patients that have had STDs, or heavy metal exposure. All right, the DRE is the most effective, but we do use both a DRE and a PSA. You want to draw your PSA before you do the rectal exam because that can cause it to go up some. If there's a suspicion, they will biopsy the prostate per transrectal ultrasound biopsy. If cancer is present, they will work them up for metastasis to be sure there isn't any with an MRI, a CT scan, or a bone scan. As I said, prostate cancer is slow growing, so just because you are diagnosed with prostate cancer does not necessarily mean you're going to have surgery. Sometimes, depending on the age of the patient, the symptoms, we just treat symptoms and watch. They will have PSAs and DREs done at regular intervals. If a biopsy is done, they will have mild pain for 2 to 3 days. They may go home on antibiotics. Their activities are usually restricted for the first 24 hours. We want them to drink a lot of fluids. Their semen can be discolored for up to a month. They can have blood in their semen. They may have mild increases in temperature, but of course want to notify the physician if there's fever, shaking, chills, if they seem to be getting an infection. They may have some discharged blood in the urine for a couple of days after the biopsy, but if it persists for longer than 2 or 3 days, they also need to notify the physician or healthcare provider. Laparoscopic radical prostatectomies are done for PSAs less than 10. Post-op of a radical prostatectomy is usually retropubic to preserve perineal nerves. A prostatectomy, of course, is removal of the entire prostate gland, the capsule, the cuff at the bladder neck, the seminal vesicles, and regional lymph nodes. The urethra is anastomosed to the bladder neck. You need to watch for infection, for drainage, for big clots, SCDs, TEDs, the usual post-op. But these patients also need to avoid straining at stool because it can cause bleeding, so they may be on stool softeners. They can have small clots in tissues passed for up to 2 weeks post-op. Prostatectomy patients do not need to take tub baths because it dilates the pelvic blood vessels. Depending on the MD, no sex, no driving, no exercise, heavy exercise for 3 to 6 weeks. Depends on the physician. With the LRP, one nice thing about it is that the catheter post-op is usually only about 7 to 14 days. It can be up to 2 weeks longer with a radical procedure, and these patients do go home with a Foley catheter. Antispasmodics decrease bladder spasm, which can damage the bladder incision, such as the Bentyl and Anaspaz that we've talked about. One of the complications is urinary incontinence. Their sphincters can be damaged, so we can teach them Kegel exercises, contractions, and relaxation of the perineal and gluteal muscles. Page 1722 gives you a little tutorial on that. Erectile dysfunction is the other big problem, complication, if the pudendal nerve is severed or damaged. Non-surgical management can be radiation, hormones, chemo. Radiation is usually for locally contained tumors as an adjunct to a radical prostatectomy. We can do external beam therapy for 5 days a week for 6 to 9 weeks. And again, erectile dysfunction, acute radiation cystitis, proctitis, fatigue can occur from this. Internal radiation in the early stages of prostate cancer, it's low dosage. ED is another, in urinary incontinence is also a side effect of this. Hormone therapy is an androgen deprivation, or they can have bilateral orchiectomies. When you deprive of androgen, at first we have stimulation of the luteinizing hormone, but then the pituitary runs out, which decreases testosterone production. Leuprolide or Lupron is an androgen therapy drug. It can cause hot flashes, erectile dysfunction, decreased libido, gynecomastia, osteoporosis, and we use Iridia to prevent bone fractures. Anti-androgen drugs that block the body's ability to use the available androgens, flutamide or Ulixin is the trade name. Chemotherapy can be used when there's metastasis, when other therapies haven't worked. All right. Erectile dysfunction is the next thing we're going to talk about. Causes of this are inflammation of the prostate, pelvic fractures, surgery, drugs, antihypertensives, diabetes, hypertension, smoking, alcohol. Secondary reasons such as psychological, periods of high stress, which can occur suddenly, and they usually, with the psychological erectile dysfunction, these patients usually have normal nocturnal and morning erections. And remember that Ms. Hall talked a lot about antihypertensive drugs, and how this is one of the side effects that men tend not to talk about, but they'll come off their drugs because of it. But as she said, we've got lots of different antihypertensives. We need to be proactive in seeking out these patients to keep them from having renal damage. Nothing to add to the assessment. The Viagra and Levitra, I can't pronounce those words very well, so we'll go with Viagra and Levitra, are the short acting within a half an hour to an hour. Cialis is the weekender drug. They are PDE5 inhibitors. They cause muscle relaxation of the corpora cavernosa and increase blood flow to the penis. Veins exiting are compressed. Of course, one of the big side effects to this is prolonged erection or priapism, and you may see Demerol used to try to help that for the hypotensive effects to decrease the blood flow. Always need to watch when we come in, and I'm sure you talked about this in Module B, about asking your patients if they're on erectile drugs, if they come in with chest pain, because they can cause major hypotension if we give them nitroglycerin. I'm going to let you look through the rest of these on your own. All the information is there. This is a family who he did have cancer and did sperm donation. They discovered his cancer when, I think, right after they got engaged. He did sperm donation, went through all his chemo, and he now has 3 beautiful little girls. All right, the only thing I was going to add to this that's not on here is these patients also have an absence of the cremasteric reflex, and they'll prevent with nausea and vomiting, acute scrotal pain, edema, and it can occur after a trauma. And I think I just said edema, and I meant to say scrotal pain. They don't necessarily have edema. This is from your book, so you can look at that. Here I wanted to add that in children, phimosis can be corrected through cleaning and gentle manual retraction of the prepuce. Paraphimosis or retracted skin, it cannot be returned. Why does that happen? We can do it if we don't put our foreskins back down when we put Foley's in or do cath cleaning, perineal cleaning. Some treatments for this, you may see barbiturates used because it suppresses REM, prevents the normal nighttime erection. I'm sorry, the barbiturates are used also after surgery to prevent that erection so that the sutures aren't pressure being put on those. They do use absorbable sutures, so and there's no residual side effects after this. Post-op patients can resume activities after a week, resume sex after 2 weeks. Priapism, let's see, here we go. Uncontrolled, long-maintained erection. After 4 hours, the blood becomes trapped. It's unable to drain. It can lead to scarring and permanent erectile dysfunction. This can be caused from medications, from trauma. Sickle cell, approximately 42% of patients with sickle cell anemia can have this problem occur. And there are 2 categories: low blood flow, where the blood is trapped in the chamber, such as with sickle cell, leukemia, malaria, because of the changes in the cells, or high flow, which is more rare because of a ruptured artery from injury. We're going to use several things to manage this. Ice packs can be used to decrease the swelling. Intravenous, intracavernous injection of alpha agonists, which veins narrow, reducing blood flow to the area, or actual aspiration of the blood, the extra blood that's in there. With this one, I wanted to add that Epididymitis causes scrotal pain, fever, nausea, vomiting, chills. Hypospadias, repairs are done before preschool years to allow for achievement of sexual identity, avoid castration anxiety, facilitate toilet training. And I want to congratulate y'all. You did a great job on your CAT exam. We were very excited. And just study. Take a little time to relax, and y'all are going to knock out this exam on Wednesday, and you'll be done. Yay! All right, see you next week.